volume all right? Okay, so tonight I'm going to talk about healthcare-associated infection, or HAI, surveillance. And I've subtitled this a partnership of disciplines because it really involves the infection prevention and control of the IPC team and microbiology to work hand in glove in order to have an effective HAI surveillance program. So tonight I want to talk about, I'm going to talk about the epidemiology of HAIs. I want to talk a little bit about the risk factors. I'm going to look at four definitions, definitions for four HAI, healthcare associated infections. And then I'm going to speak about the role that microbiology plays in HAI surveillance, but also the role of microbiology in the antimicrobial stewardship programs that are necessary in trying to control antimicrobial resistance. And there is a very distinct link between HAI surveillance and AMR surveillance, and that's why there is a partnership between the IPC team and the microbiology department. So in talking about HAIs, it's important that you know that the definition of an HAI is an infection that occurs in a patient during the process of care in a hospital or other healthcare facility, which wasn't present or incubating at the time of admission. And this often includes infections that are acquired in the hospital, but that don't appear until after discharge. And it's important for us to keep in mind that occupational infections among staff, and as we spoke about last week, the risk, particularly in microbiology and in the laboratory setting, those occupational infections among staff members are also healthcare-associated infections. So it's another important area to watch for. The true global burden remains virtually unknown because of the difficulty that there is to actually gather reliable data. HAI surveillance is complex, and it requires the use of standardized criteria, the availability of diagnostic facilities within the healthcare facilities, and the expertise not only to conduct this surveillance, but also to interpret those results. And so surveillance systems for HAIs exist in most high-income countries, but they're virtually non-existent in low and middle-income countries. And in fact, only 23 developing countries out of 147 reported having a functioning HAI national surveillance system in 2010. And the reason for that is surveillance is a resource-demanding activity, and it requires appropriate training for its implementation. And in many poorly resourced countries, not only is the training not available, but often there isn't even adequate human resources to assign to IPC duties. HAIs occur both as part of an endemic ongoing trend within healthcare facilities, but it also occurs in epidemic situations. That is, when new cases in a given population during a given time period substantially exceed what was expected based on the normal endemic data. And the endemic situation and the occurrence of outbreaks in healthcare settings are important indicators of the quality and safety of patient care in those facilities. For this reason, surveillance is at the heart of all control programs. According to the WHO, in a report that they released, the report on the burden of endemic healthcare-associated infection worldwide, the prevalence of hospitalized patients who acquire at least one HAI ranged from 3.5% to 12%. And when looking at disaggregated data between high-income countries and low and middle-income countries, you can see that in the latter, shown on the right side of the screen, in the latter, the prevalence is quite extensive, and healthcare-associated infections are more frequent in resource-limited settings than in developed countries. And at any given time, the prevalence of HAIs vary between 5.7 and 19.1% in those low and middle-income countries. WHO goes on to note that HAI prevalence figures reported in their most recent studies that were available from high-income countries, shown in this figure, range from 3.6% in Germany to 12% in New Zealand. But additionally, 13 out of 28, or over 46% of the European high-income countries reported either ICU-acquired infections, surgical site infections, or both to their regional surveillance networks. And the reporting, that aggregate reporting, is really important because it allows us to have a more consistent and accurate picture of the true reflection of HAIs in those countries. But the risk of HAIs is significantly greater in low and middle income countries. Overall, the incidence of HAIs and device-associated infections from patients, I'm sorry, my graph got lost here. Oh, this is an extra slide. I apologize. There. The risk is significantly greater, and you can see that there was a prevalent, that what the incidence is here is 17 HAIs per 1,000 patient days. And when you look at catheter-associated urinary tract infections, it was 4.1 per 1,000 urinary catheter days, and the ventilator-associated pneumonia was 7.9 per 1,000 ventilator days. And what's really important to remember is that oftentimes the catheter-associated urinary tract infections can lead to bloodstream infections and sepsis. And when sepsis develops, then the risk of death increases, or the risk of mortality increases. So you can see here, when you look at what happens in the low and middle income countries as opposed to the high income countries, those are more than twice as high. So in the low and middle income countries, you're seeing an incidence of 47.9 healthcare associated infections per 1,000 patient days, and the CAUTIs doubled to 8.8, and the ventilator associated pneumonias are almost 3 times as high, with 23.9 per 1,000 ventilator days. The risk factors for HAIs vary according to not only the type of healthcare facility, but also to the care area where the patient is admitted. And they're partially different in developing countries. In studies that were conducted hospital-wide in high-income countries, the most common factors that were independently associated with HAI occurrence were age greater than 65 years, admission as an emergency and to the intensive care unit, hospital stays that averaged longer than 7 days, and then the placement of invasive devices, specifically indwelling urinary catheters, endotracheal tubes, central venous catheters, but also patients undergoing surgery, those that had trauma-induced immunosuppression, neutropenia, and a rapidly or ultimately fatal disease. The same risk factors were identified in acute care settings in low and middle income countries as well, but there also were additions of other determinants that are more broadly associated with the level of poverty that you see in those countries, such as the lack of basic hygiene and limited resources. And so this includes then the addition of malnutrition, children who are less than 1 year of age, low birth weight babies, receiving parenteral nutrition, and those with 2 or more underlying diseases. So you can see that while the type of facility and the type of care are more, excuse me, are more significant, you also do have to take into effect those other basic hygiene and limited resource components as well. So now I'm going to talk a little bit about the risks themselves. So when you talk about the pathogenesis or the routes of transmission with the central venous catheters, it's really important to note that the the microbes themselves are resident on the skin at the insertion site, and what happens then, excuse me, what happens then is that as the catheter is inserted into the central vessel, then it does allow for migration of the organisms down in. And then the longer that the catheter is in place, what happens is that you develop that fibrin sheath around the end. And you can also develop biofilms. And biofilms, we're going to talk about them in a few minutes. So how else then do these catheters become contaminated? Well, obviously direct contamination on the surface. So at the hub, when you are connecting and disconnecting to hang fluids and such, then you can contaminate the catheter then, as well as hematogenous seeding from remote sites. So remember, I talked about the occurrence of catheter-associated urinary tract infections, and then they can actually seed and lead to bloodstream infections. And then less frequently seen, although still a significant factor around the world, is the infusion of contaminated fluids or infusates. So with this one, it's really important to note. So this is the intrinsic and extrinsic risk factors for the development of central line associated bloodstream infections. And you can see on the left-hand side of the screen that there are some intrinsic risk factors that we have no capacity to modify. You can't change a person's age, you can't change their underlying diseases, and you can't change their gender. Excuse me. But when you look at other risk factors that have the potential for being modified, then you can look at that are associated with both the insertion of the central venous catheter or the maintenance of the central venous catheter. Then those are the factors that are targeted. Those are the factors that are targeted for trying to prevent bloodstream infections. So if you talk about multiple CVCs, one of the factors there is not using central venous catheters, CVCs or central venous catheters, unless you have to. And then if you do have to use central venous catheters or CVCs, it's important that you only insert catheters with the number of lumens that are necessary. So if you only need to insert a single lumen central venous catheter for, say, just the infusion of fluids, then, and you aren't going to be doing hemodynamic monitoring and all of that at the same time, then you could insert a single lumen CVC as opposed to a double or a triple lumen CVC. And then another area is that the femoral site, which is one of the easiest for insertion of central venous catheters, is actually the most heavily contaminated. And so a femoral site is the site of last choice for inserting central venous catheters. The internal jugular is the second least favorable site. And so it's important to know that when you insert central venous catheters, you would want to insert them in the subclavian if at all possible. And then during the insertion process, we've come to realize that it's important to use maximal sterile barriers during that insertion procedure. So it's almost like dressing up like you were going to be in an operating theater for the insertion of a central line. And then CVCs that are inserted in ICUs or emergency departments have higher risk factors. And so particularly those that are inserted in the emergency department under emergent situations with less than maximal sterile barriers, then they could be replaced as soon as possible so that they are inserted in a more sterile manner. So when you talk about uropathogens and the use of urinary catheters, it's important to note, first of all, that we talked about how significant the incidence of urinary catheter-associated urinary tract infections is, and in fact, approximately 12 to 16% of adult hospital inpatients will, first of all, have an indwelling urinary catheter at some time during their hospitalization. And each day that the indwelling catheter remains, the patient's risk of acquiring a CAUTI, or a catheter-associated urinary tract infection, increases by 3 to 7%. So after 7 days, you could see that they already have a 20% risk, at a minimal 27 to 50% risk of having a urinary tract infection. But bacteria enter the urinary tract infection by two possible routes. So the first one is the extraluminal route. So that happens early at the site of insertion. So as the catheter is inserted, then there is an introduction. Then there is an introduction of microbes that are placed and driven all the way up to the bladder, where they can then begin to multiply. And then between the catheter and the surface epithelium of the urethra is where that takes place. So that extraluminal infection occurs when those skin colonizers colonize the external catheter surface, and then they migrate. The intraluminal route, the intraluminal infection, is caused by organisms gaining access to the lumen of the catheter, either from failure of the closed drainage or the urine in the collecting bag, or the collecting bag getting contaminated. And so while extraluminal ascension of microorganisms may be more common, both routes are important. And the interluminal happens when there's a break in the closed drainage system. And oftentimes this will happen when people either disconnected to empty the bag, or they disconnected to collect a specimen, as opposed to using the collection port and collecting it that way. So it's really, so those are the two main risks for urinary tract infections associated with urinary catheters. And then when you talk about the epidemiology of ventilator-associated pneumonia, data from the Caribbean region is actually fairly sparse. CDC, Centers for Disease Control, definitions are usually adopted for use, but in many instances can't be applied because the facility doesn't have access to the data and the diagnostics, which may be required to meet the content of that definition. But it's important to note that ventilated and intubated patients generally stay longer in ICU. And this, of course, the longer that you're in ICU, the more likely you are to get an infection. But it is the second most common healthcare-associated infection, and it's the leading cause of death from healthcare-associated infections in critically ill patients. So when you talk about those risk factors which are modifiable or not easily modified with respect to the ventilator-associated pneumonias, again, you have some not easily modifiable factors. Patients with chronic lung disease are at higher risk for pneumonia. Patients that are greater than 60 years old. So chronic lung disease provides increased risk because of the already compromised lung tissue. When you talk about the severity of illness, this is a score that's used to measure the overall risk. Persons over 60 years of age are at higher risk of developing ventilator-associated pneumonias if they're intubated and ventilated. And then with respect to the head trauma, the cough reflex, which is centered in the central nervous system, it's depressed, secondary to the trauma, and so they're with the head trauma, then they have a decreased cough reflex, and that prevents them from adequately clearing the microorganisms from their upper respiratory tract. And the risks are similar with the head trauma for patients who have had neurosurgery. Any and other surgery, especially surgery of the upper abdomen and the thoracic surgery, interfere with the respiratory dynamics. In acute respiratory distress syndrome, or ARDS, is actually a complication of mechanical ventilation trauma. But when you talk about those that are modifiable, then the duration of ventilation from point of intubation must focus first and foremost on once you ventilate, you start with a plan for how soon can you extubate the patient. So, and that's something that needs to be addressed daily, is how soon will they be will they be extubating? Because the longer a patient is on the ventilator, then the more likely they are to develop a ventilator-associated pneumonia. With the use of barbiturates and sedation, the sedation interferes with the natural reflexes, and so that was important to note as well. And then for a while, we used to think that the use of H2 blockers or antacids helped to prevent ventilator-associated pneumonias. But when they actually went back and did a review and put all the data together in meta-analysis, it was shown that the use of the H2 blockers or the use of antacids actually increased the risk. And so that was one that was changed immediately, is that you shouldn't be using H2 blockers or antacids in persons who are on ventilators. And the more frequently that the ventilator circuits are changed, the reason is that the more frequent changes cause an imbalance in the pressures between the internal and external pressures. And so the ventilator circuit changes should be at less than 48 hours. And we're going to talk about the use of bundles a little further on. And the bundles have been successful in modifying the risk factors and decreasing the occurrence of healthcare-associated infections, or HAIs. So with the pathogenesis for the ventilator-associated pneumonias, or the VAPs, I'm gonna start first of all with a brief discussion about the susceptible host. So patients lose their defense mechanisms for avoiding reflux or of gastric fluids, or even secretions in the upper airway when you intubate the patient. And one defense mechanism is that reflex to cough and swallow, because it's blocked by the actual presence of the tube in the presence of the endotracheal tube. And the pathogenesis of disease in this situation can lead to the creation of biofilms, which is significant. The biofilms can actually form on the endotracheal tubes. Colonization and then the lead up to the development of biofilms, the colonization of the ET tube actually occurs within hours. And once it's formed, the biofilm can actually migrate into the lungs. And for those of you that were here last week, I spoke briefly about biofilms and how significant they are with that mat-like structure. And it's very difficult to penetrate those. And so once they form, they're very hard to eradicate. At the patient level, the aspiration of the secretions can lead to the colonization or infection, and it can result in hematogenous. You can also get hematogenous spread from distant sites, such as colonization via digestive tract or bacterial translocation from the gut. And the culmination of all of these factors can lead to the development of ventilator-associated pneumonias. So how do you prevent healthcare-associated infections? Robust evidence indicates that healthcare-associated infections can be prevented and the burden reduced by as much as 50% or more. And this can happen in these situations when you have an active IPC program, which includes training and education for healthcare workers. So training them on the risks and training them on the practices that need to be modified, and making sure that they understand the consequences of those risks and the development of the HAIs. The second component that's critical is conducting surveillance for HAIs using validated and standardized case definitions. But it's not good enough to just do the surveillance. You have to report and feedback. So you have to make sure that there's feedback to the appropriate stakeholders. And then the last one is the use of bundles, and I talked about that. Care bundles have shown significant impact on the prevention of healthcare-associated infections. There actually are bundles that have been developed for the prevention of central line-associated bloodstream infections, bundles for the prevention of catheter-associated urinary tract infections, bundles for the prevention of ventilator-associated pneumonias, and bundles for the prevention of SSIs. So what are bundles? So basically, care bundles are simple sets of evidence-based practices that, when implemented collectively, have shown to produce better outcomes and have a greater impact than that of the isolated implementation of the individual components of those bundles. So it improves the reliability of their delivery, the components of the bundles, and all collectively, it improves the patient outcomes. But in order for the bundle implementation to be successful, each element of the bundle has to be implemented collectively with complete consistency in order to get those favorable outcomes. So in other words, with the use of bundles, it's an all or nothing type of approach to this. But they have shown significant success in preventing HAIs and reducing the burden of HAIs in healthcare facilities. So I'm going to talk about the actual HAI surveillance itself. So if HAI surveillance is necessary in order to reduce the prevalence, what does it really entail? And so here I just want to talk then about, first of all, you have to know what surveillance is. So surveillance is usually defined as the ongoing and systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice. And the specific goals of surveillance may vary somewhat depending on who is conducting it and the population under study, and may include any or all of the following: establishing baseline or endemic rates of disease, the identification of disease outbreaks or changes in the disease trends that are being seen, and determination of risk factors for or the natural history of specific diseases, the measurement of compliance with those established standards. And while it's termed surveillance here, it also is referred to as monitoring and evaluation. And then also the assessment of the effects of practice changes, new interventions, or new technology. So that is, in a nutshell, that's what HAI surveillance is. But as I stated earlier, it's complex. And so let's take a look at it. So, and the things I want to, the components of surveillance that I want to stress to you is that it has to be ongoing and there has to be systematic collection. So in other words, if you talk about systematic collection and then collation analysis, then that means you have to be documenting this information that's being collected. So we'll break it down a little bit. So the ongoing collection and collation means that it's continuous, not haphazard, and you collect the data or information, and then you group them based on their similarities. The analysis, after the data is grouped, you have to analyze or examine the data, and then the timely dissemination, providing that information, providing feedback to members of the healthcare team and other stakeholders is important. And the data that I'm referring to then is data for action. In other words, you're not just collecting the data and filing them somewhere, but you're accumulating the data and then using them ultimately to improve the quality of healthcare and the outcomes that are being measured, which in this instance is healthcare-associated infections. So in looking at it, what do we use this information for? So we use the baseline rates of outcomes or processes. And so initially you're doing this. If there's an interest in implementing an information, you have to know where you start, and then you have to know what's the difference. So what is the difference in the data after you implement that intervention? It's also incredibly important for monitoring trends. And these trends can be monitored annually or monthly or even weekly, depending on what's being monitored. But it's critical to be able to understand what those trends look like over time. With surveillance, we have to be able to detect outbreaks. It's possible to detect outbreaks if surveillance is being used to monitor those trends, because an outbreak is essentially something over and above the normal of what you're usually seeing or above your facility. So if a facility is monitoring trends regularly and notices that there's suddenly an increase in a particular type of infection, that's one way that you can identify outbreaks. We also use surveillance to evaluate the effectiveness of IPC measures, to really understand whether the measures that are being implemented are reducing the number of healthcare associated infections. So if there's a lot of effort going into prevention and control measures, but you're still observing a lot of healthcare associated infections, then you have to reevaluate whether those measures are working as they're supposed to, or whether those measures weren't implemented the way they were designed to be implemented. You can use surveillance to monitor the effectiveness of interventions to know, the effectiveness of the interventions, the effectiveness of the control measures. And then also, it's important that you use this information to target improvement activities. So what intervention should be implemented, and then the areas, then looking at it afterwards, the areas where work can still be done or improvements can still be made. And finally, it can be used to identify diseases and organisms of epidemiological importance. So, for example, the carbapenem-resistant organisms, sometimes something that are identified require an immediate response, and in that instance, that's what surveillance is supposed to do. So for the carbapenemase producing organisms, that should be considered like an alert organism. So surveillance should be picking this up. And this is why microbiology and the IPC team should be working hand in glove together for the prevention of HAIs and the control of outbreaks. So when we talk about healthcare associated infection and key concepts, the first concept I want to talk about is what population are we interested in? And so for HAI, for HAI surveillance, it's called the at-risk population. And how do we find that population, and how do we identify them? So say we're interested in conducting surveillance for surgical site infections. So we might want to conduct surveillance among the population of men and women who have had a surgical procedure. So that would be our population at risk, as opposed to all of the individuals in the hospital, some of whom may not have had a surgical procedure. But what if we're interested in a more specific subset? Say we're interested in looking at cesarean sections or C-sections. So then what we could do is we could follow just those persons who have had C-sections to see what type of HAIs are being developed. When you talk about the methodology for HAI surveillance, WHO recommends that surveillance be conducted, be active. In other words, and it requires review of records in order to actively identify the cases as they arise. So you wouldn't be wanting to do, so it should be active, selective, prospective, and patient-based. So there should be a proactive approach to identifying those. And then it should be selective. In other words, they don't recommend that you go out and that you look for every single infection that every single patient in the hospital may develop. So the purpose in doing the surveillance is to be able to implement interventions that will prevent it. And we know that some patients are going to acquire HAIs that we don't have interventions for. And so if you count them, you've got this data, but you can't do anything with it. So you want it to be selective in that you want to survey infections for which we have interventions, for which we can implement prevention methodologies. And so they're selective. And prospective means that you should be actively looking for infections while the patients are in the healthcare facility. When you are doing retrospective chart reviews, a lot of times you miss the opportunities to ask questions. You may have something going on that you didn't know about, and you missed an opportunity to intervene and prevent them. So it should be prospective, and it should be patient-based. So when you talk about case finding, this involves somebody who's a trained IPC professional identifying patients who are suspected of having the specific infection under investigation, and then collecting the corresponding denominator data. So you have to. We're going to talk about the numerators, and then I'm going to talk briefly about denominators as well. But if the terms are new, don't worry about it. But case definitions, this is the most critical point here about case definitions, is you have to have criteria that is uniformly applied, and that is part of the training for persons who are going to be doing HAI surveillance. It's important that they understand how to review the charts, how to look at the clinical information, the diagnostic information, and determine whether or not they meet the criteria for this. So it's not necessarily the same criteria that is applied for clinical purposes. So you should never confuse the conduct of HAI surveillance and the definitions that are used for that as the same as for how a patient would be diagnosed for clinical purposes, because they are two very different beasts. The surveillance definitions are simply a methodology that we can use to count what is most likely a healthcare associated infection, and then allows us to apply interventions or bundles or prevention measures that will begin to decrease the number of patients who develop those HAIs. When you talk about when you look at this, it's important because if you're using that case definition and you're only taking what a doctor says is an infection, you're going to miss some. And then sometimes doctors may say patient has an infection, but there's no supporting criteria. And that's part of the reason why the criteria for surveillance is different than the criteria for clinical purposes, because you're not trying to tell the doctor that be treated. That's a totally different beast. Case confirmation, there should be confirmatory information that is used, and this is how you confirm that they meet the criteria for that case definition. And it's done through records from the laboratory, pharmaceutical, medication, administration records, patient admission information, discharge and transfer summaries, imaging reports, pathological and anatomy databases, and it can include interviews with physicians and nurses as well, and also review of the notes. So the doctor's notes, the nurse's notes, those are all part of how you do the case confirmation to say that a person has an HAI. not that the person has an infection that needs to be treated. And then how often should you be conducting surveillance? Because it is this is a critical component, this, like I said, HAI surveillance is a hallmark. It's a cornerstone of IPC programs, and it is recommended that in order to be able to carry out surveillance in an intensive care unit, and be able to capture and review all of the information that is collected on those patients at any given time, you should be visiting those intensive care units at least twice a week. And this can become, so you can see where this is a labor-intensive process. And in fact, surveillance oftentimes will dominate the activities of an infection control team. But the data, once the data is collected, it should be consolidated monthly for the hospital use. Okay. So, some important considerations to take into account when conducting HAI surveillance. Laboratory surveillance should not be used in isolation. So, for example, if we're conducting surveillance for central line associated bloodstream infections, having laboratory evidence of that infection is a critical component, but you also need additional information. So you need to know, is there a central venous catheter? And the laboratory wouldn't know necessarily if that patient has it. So there are additional components that need to be taken into account. And the other one is that sometimes devices are inserted outside the unit. So if you're conducting surveillance for an ICU and the patient is transferred to that ICU already, then it changes how you would count that infection being applied as an infection of the ICU as opposed to another area. So so it's important to note that where these devices are being inserted, and then when does the infection develop? And we're going to talk a little bit about that as I go through the case definitions. So some of the measurements that we use in reporting surveillance data, obviously we're doing measures of frequency, and the two most important ones that we're going to focus on are going to be the prevalence and the incidence. And you can do point prevalence, or you can do period prevalence. In the European Union, they do annually, they do point prevalence surveys in healthcare facilities and are able to give a snapshot of the types of infections and the amount of infections that are being seen. I said that there are two key terms that are important: the denominator, so that's the population that's at risk for that infection that you're looking for. So how many people are at risk for getting it, and then the numerator, how many people actually do acquire that infection. And just remember that the numerator is a subset of the denominator, so the persons in the numerator have to be counted in the denominator when you do them. We talked about doing surveillance for C-sections, so then the denominator would be all of the women who had C-sections, and then the numerator would be the number of women who develop a surgical site infection as a result of that cesarean section. And so the numerator, the women who have the infections at the incision site, have to be included in the denominator in your counts. So I talked about some of the measurements that are used, and I'm going to mostly focus on prevalence and incidence, but the proportion is the proportion is a ratio. The numerator is a subset of the denominator. It can be expressed as a decimal, a fraction, or a percentage. The prevalence is a type of proportion, and the numerator is a subset of the denominator. And what you have to keep in mind here is that prevalence includes not just new cases of the outcome, but also those that are already existing. And I'm going to show you that more graphically in just a moment. So it's just the number of patients, for example, who, if you're doing point prevalence, it could be the number of patients who have HAIs on a particular day. So it could be people who have new infections, people who have old infections, existing infections. And so it counts new and old cases at the same time. I'm going to talk a little bit about what impacts the level or the number that you would get, the prevalence. The rate is different from prevalence in that it's looking at the frequency with which an event is occurring. And then when you talk about incidence, the incidence is only looking at the new events. So if you were doing rates in a hospital for healthcare associated infections, frequently you're only looking at new infections because you are reporting it for a specific time frame or per a specific number of procedures. So what's the difference between incidence and prevalence? And we said incidence is new cases, and the numerator includes only the new cases during a specified time period, and the prevalence is the existing cases, and the numerator includes old and new cases during that applicable time frame. So graphically, it looks like this. And so it's important to know then that if you think of having a vessel with a spout and a drain, the incidence is all the new cases that are dropping in. And so this is what you would be counting if you were looking at incidence. But the prevalence is everything that's already in the pot. So the prevalence includes these new cases that are being dropped in, plus the ones that are still sick that haven't been cured. So the only way that prevalence drops then is when there are cures or when there are deaths, and those ones then would exit from the vessel. And then I'm not going to go over these rates. It's just to give you an idea of the types of indicators, surveillance indicators that can be and often should be monitored within healthcare institutions. So surgical site infections, particularly, and surgical site infection surveillance can apply to not only inpatient hospitals, but also to outpatient surgical centers. They should be monitoring their surgical site infections. And then also I talked about the central line associated with bloodstream infections, which are a subset of bloodstream infections in general. Catheter-associated urinary tract infections, ventilator-associated pneumonia rates, and then also another important rate is the multi-drug resistant organism rates. For example, you might report MRSA rates, or you might report carbapenem-producing enterobacteriales. So these are important things to keep in mind. These are the types of rates or indicators that should be monitored in healthcare, in IPC programs, in healthcare institutions. So the next component I want to talk about are the case definitions. And the use of standardized definitions is crucial because you need it for the reliability of that HAI surveillance information. And these allow us to establish that infections were acquired during the hospital stay, to ascertain that the condition is a true infection and not a colonization or contamination, and that accidental presence of microorganisms in normally sterile body sites or fluids don't reflect actual infection status, it's important that we are able to compartmentalize those different types of situation. But according to the WHO, the most reliable definitions for HAI surveillance are those that are issued by the United States National Nosocomial Infection Surveillance System. And these were all recently revised by the National Healthcare Safety Network, which is a department within the Centers for Disease Control. And it is actually their healthcare associated infection tracking system. So I'm going to present case definitions for the 3 most common device associated infections, as well as surgical site infections. And what I really want you to know is that these are brief descriptions of these infections only. The manual that guides this surveillance tracking system is 445 pages long. And then in addition to that, when we at PAHO do training for IPC staff in order for them to conduct healthcare associated infection surveillance, we provide approximately 8 hours of lectures and practical exercises for the introductory training as part of a broader advanced IPC training program. So I just want to preface this with that comment, because we are really just brushing the surface of HAI surveillance. So there are three types of bloodstream infections: primary, secondary, and mucosal barrier injury laboratory confirmed bloodstream infections. And this last one, the mucosal barrier injury, this is limited to patients who meet one of 2 very specific criteria and do not apply to the general population within the hospital. And the 2 criteria are that the patient is an allogeneic hematopoietic stem cell transplant recipient within the past year, with one of the following documented same hospitalization as the positive blood specimen. In other words, they have to have a hospitalization at the same time as the specimen was collected. They have to have a grade 3 or 4 gastrointestinal graft versus host disease, or they have to be having greater than or equal to 1 liter of diarrhea in a 24-hour period, with onset on or within 7 calendar days before the date of the positive blood culture was collected. Or the patient has to be neutropenic, which is defined as at least 2 separate days with absolute neutrophil counts and or WBC values less than 500 cells per cubic millimeter. So this mucosal barrier injury laboratory confirmed bloodstream infection is a very specific and very unusual type of thing, and it's not usually seen in just general hospitals. So the main focus for bloodstream infection surveillance in healthcare facilities is the primary bloodstream infections, the secondary bloodstream infections, and the central line associated bloodstream infections, which is a subset of laboratory confirmed bloodstream infection. So those are the ones that we're going to talk about, that I'm going to talk about now. So this LCBSI is a laboratory confirmed bloodstream infection. So laboratory confirmed bloodstream infection 1 is culture based only and doesn't require any additional information. So you can see here, this is LCB1, LCBI1, and the patient has a recognized pathogen, and they have very specific guidelines on what is considered pathogenic versus what is considered common commensals. So they have a blood culture that is 1 or more blood cultures with a recognized pathogen, okay? And those pathogens or those microorganisms cannot be included in the common commensal list. And the blood culture pathogen is not associated with infection elsewhere. So that is LCBSI1. And LCBSI2 an LCBSI2, patient has to have at least one of the signs or symptoms, so either fever, chills, or hypotension, and they have to have signs and symptoms and a positive lab result not associated with an infection elsewhere. In other words, it can't be a secondary bloodstream infection. And they have to, in addition to that, then they also have to have isolation in 2 or more vials of blood cultures collected on separate occasions at different times, with a maximum time between the 2 blood cultures of 48 hours of a common commensal microorganism. And so the importance of that is that it has to be in 2 separate blood culture sets. So if somebody has a coag negative staph, or like a staph epidermidis, and they've drawn 2 sets of blood cultures and only one is positive for it, then the patient doesn't meet criteria for LCBI1, nor does it meet criteria for LCBI2. So those are important things to note. LCBI3 is specific criteria for patients that are less than or equal to 1 year of age. And it's a combination of signs and symptoms and positive blood cultures. And again, it's in at least 2 blood culture sets. And this is a change because in neonates, frequently they will only draw 1 blood culture because of the concern for anemia with too much blood draws on patients. So it's very difficult in the setting where you have neonatal intensive care units, or you have high dependency units where you're trying to do surveillance on these infants, particularly the small birth weight, the low birth weight babies, and they're only collecting 1 blood culture. You can't confirm according to this surveillance criteria that the patients have bloodstream infections. And then within the context of this surveillance system, there are extensive notes that are provided to give you additional information. And they give guidance, such as if a patient meets criteria for LCBI1, LCBI2, or LCBI3, you would report it as LCBI1 because that would be the highest level. Okay. And then once you meet the criteria for LCBI1, you don't need to have any other documentation other than that is it. And I'm going to talk briefly in a minute about the bloodstream, the infection window period, and a couple of other key terms. So when you talk about this system, and like I said, this is a over 400-page guidance document on how to conduct this, and they set up. Sorry, this is a comment. This came from this had been interpreted. It had been translated into Spanish, and then we translated it back to English and missed a couple. But anyway, when you look at this, you have to look at how long, because remember now, we said at the beginning that that it has to be associated with the admission. So you can't have healthcare associated infection happen on the day of admission, because the incubation period for the diseases that are being followed is usually longer than that. So this takes into account how much time and each of the different criteria for all of the different types of healthcare associated infection will give guidance similar to this. So they talk about the day of the event, which is the day that the first sign or symptom or laboratory confirmation or imaging takes place. And then they talk about how many days the patient has to be in the hospital before you can call this a healthcare associated infection. So this is the day of event is what I said. It's what is the first indication that the patient has a healthcare associated infection. And when you talk about the window period, it's the period of 7 days in which they have to meet all of the site-specific infection criteria in order to be classified. So you would look at a blood culture, the patient has to be in the hospital for 3 days, and then on day 4, which would be day 0, they might have a positive blood culture for E. coli. So in order for them to meet the criteria, it's a little easier to see it if it's like with a staph epidermidis or something, because then you can start to see with the staph, then you would have to have fever or whatever. So you can see it here where you had fever on that day and then you had a blood culture. So this needs to be calculated for every single healthcare associated infection that you have under surveillance for the patients when you do the documentation. And then in order to prevent counting a reemergence or a complication and over counting, calling it a new infection when it actually is still just a continuation of a previous one, they have something called the time of recurrence of infection. And so the time of recurrence of infection is generally about a 14-day, it's for bloodstream infections, it's a 14-day period. And what this reflects is, this reflects the amount of time of the natural progression and treatment and clearing of a bloodstream infection. So if in this time frame, say here, you had recultured the blood and it still had E. coli in it, then you would say that this is still part of the same infection. And so you wouldn't want to call it a new infection. It would skew your data when in fact it is treatment failure and it is still part of the same infection that you've already counted. And then for secondary bacteremias, for secondary bloodstream infections, then the attribution period is when do you have to have that specimen that indicates that there is another site. And so that occurs sorry, I'm on the wrong, that occurs here. So you can see that it's from day 1, but it's about a 17-day. It is a reflection of the 14 days here plus the 3 days here. Okay, so that is how you get the attribution period for that. And so in that time frame, in that entire time frame, you could say that there was a secondary infection, and then say that the bloodstream is actually secondary to another site. And again, there are specific guidelines on what organisms can be utilized for something like that. So, and then there are rules about where you're doing it, when you identify in your surveillance plan, you say where you're going to be doing it, then those are the only areas that you're following. But each infection has to be assigned to a location. Generally, it's an intensive care unit. You may be following neonatal intensive care units. You might be following a specific dialysis is another area where the assignment of the infection could be to the dialysis unit. And then in inpatient areas, there are transfer rules. So you have to look at where the patient came from and were they in the area long enough to say that it occurred there, or would you attribute it to the previous location? I noted that there was a specific list for the common commensal organisms, and this is an example of it. And so in order to qualify as a laboratory confirmed bloodstream infection, a common commensal must be present in 2 separate specimens drawn on separate occasions. And then this is just to give you an idea. I forgot, there are 547 there are currently 547 listed common commensal organisms, and you can see that it's listed by genus and species. Okay, pneumonias. There are 3 case definitions for pneumonias, and ventilator-associated pneumonia is a subset of pneumonias, but it is specifically associated with the use of mechanical ventilators. And then as noted here, we're not going to discuss the events other than the pneumonias themselves that are associated with mechanical ventilation. We're not going to talk about the criteria for possibly associated or probably associated pneumonias with mechanical ventilation. So this is the algorithm or the flow diagram for diagnosing for the healthcare surveillance purposes, diagnosing pneumonias. And you can see here that the pneumonias are diagnosed using a combination of imaging studies. And here, the good component about this this flow diagram is it allows you to check what they have, and you can and it also states what the criteria are for each of these. So it's a combination of imaging studies, signs and symptoms, and I'm going to show you on the next slide in a minute the laboratory findings. And by using this algorithm, it's possible for you to actually assign the pneumonia as pneumonia 1, pneumonia 2, or pneumonia 3, as you can see here, because there are different tracks, and it lists specifically what the patient has to have. So for pneumonia 1, they have to have one or more imaging results with a new and persistent or progressive and persistent infiltrate, consolidation, cavitation, or in children less than 1 year, pneumatoseals. And then they also have to have at least one of the following for the signs and symptoms. They have to have fever, leukopenia, or leukocytosis, and in persons older than 70, altered mental status with no other cause. And so you can actually check and then go back and be able to verify that you have in fact met the intent of the criteria. And so this is the first two parts, the imaging and the signs and symptoms. And then on the next page, you can see the laboratory components of it. And again, as you meet the criteria, it will tell you which category to place the patient in. It is important to note that a physician's diagnosis of pneumonia alone is not an acceptable criteria for healthcare-associated pneumonias. So unless they meet the components that are included in this flow diagram, then you cannot count it for surveillance purposes. You cannot count it as a pneumonia when you're conducting surveillance. And then when you talk about catheter-associated urinary tract infections, they're categorized as symptomatic or asymptomatic, which is what's at the here. And then the criteria, again, is a combination of clinical and microbiological data. But what is important to note is that the patient must have a urine culture with no organism identified, at least one of which has bacterium to the level of 10 to the 5th colony forming units, or CFUs per ml. So if they have a urine culture and it has 3 or more organisms, then they don't qualify for any of this. And so you wouldn't count them, but you could use this flow diagram as well to check and see if the patient meets all of the criteria that are necessary. And then if yes or no, and then you can see on the next screen. So continued from the previous slide, it's possible to identify the type of UTI that you would assign the person. So it could be an asymptomatic urinary tract infection. It could be a catheter-associated urinary tract infection. One of the important notes with this surveillance component, though, is that the tests, the urine cultures have to be taken for the purposes of clinical diagnosis or treatment, they can't be screening cultures. So if you work in a facility that does routine screening, like I know quite a few hospitals do routine respiratory specimens from patients that are ventilated. So they do ET suctioning and they will send a specimen. That is considered a surveillance culture, and it's not collected, and it can't be used for the purposes of HAI surveillance. And that is true in urine cultures as well as in the pneumonias. I'm talking about surgical site infections. Okay, so in talking about surgical site infections, surgical site monitoring requires active patient-based prospective surveillance, and that's what HAI surveillance should be anyway, is it should be active and it should be prospective. You can do concurrent and post-discharge surveillance following inpatient and outpatient operative procedures, but the important part is that if it's active and it's prospective, then you're going to have more current data. And again, interventions can be applied when necessary. So the components for surgical site infection, this describes some of the types of surveillance that can be conducted. So when you talk about the review of medical records, then you're looking at their admission, any readmissions they might have, any accident emergency department. But in the patient charts, you're looking for signs and symptoms, and acceptable documentation also could include patient-reported signs or symptoms within the surveillance period. And I'm going to talk about that as long as it's documented by a healthcare professional in the medical record. You also can use lab imaging and other diagnostic test reports, including microbiology, and clinician and healthcare professional notes. So this is the doctor's notes, but this can also include nursing notes, and then ICD-10 or ICD-11 infection diagnosis codes. But those would simply prompt you to do further reviews. You also, part of the surveillance method for SSIs can include visiting the wards and talking to the staff. The surgeon can do surveys by mail or telephone, or the healthcare facility on behalf of the surgeon can do surveys by mail or telephone, and patient surveys as well. So for SSI surveillance purposes, SSI is divided into 3 separate types of infections. Superficial infection, incisional infections occur within 30 days of the operative procedure, and the deep incisional surgical site infection in the organ space, surgical site infections occur within 30 or 90 days of the operative procedure. And so you have to follow them out for a little bit longer. So I'm going to talk about each of these 3 briefly. And I do mean briefly. So for superficial surgical site infections, I said it has to occur within 30 days of the operative procedure. It can only involve the skin and subcutaneous tissue of the incision, and the patient has to have at least one of the following. They have to have purulent drainage, or they have to have an organism that is cultured. They have to have a superficial incision that is deliberately opened, and if this is the criteria here, if it's deliberately open, they have to have at least one symptom. So they have to have pain or tenderness, localized swelling, erythema, or heat, or they can have a diagnosis of a superficial incisional surgical site infection by a physician or the physician's designee. This is the one time when a physician's diagnosis with surgical site infections, one time when a physician's diagnosis is adequate. So incisional infection, as I stated earlier, it occurs within 30 or 90 days of the procedure. It involves the deep soft tissues, for example, the fascia on the muscle layer, and the patient also has to have, they also have to meet the criteria, at least one of A, B, or C. And so for A, perineal drainage from the deep incision, that again, the incision is deliberately opened and the organism is identified, or a culture isn't done. If a culture is done and the result is negative, then that means that they can't meet this criteria. And then they also have to have the signs or symptoms, or they can have an abscess on either gross anatomical exam. In other words, if the doctor goes in for resurgery, or histopathologic, or imaging as well. And then for, oh, I forgot to do deep abscess, sorry. The criteria for the deep abscess includes, again, opening the incision, so that they're fairly similar in comment. So the next part I want to talk about is, so what is the role of microbiology? I talked about how important it is for microbiology and infection control team to work together in surveillance for HAI. And so they play a critical role. The microbiologist, as you're aware, should be a permanent and active member of both the Infection Control Committee and the Antimicrobial Stewardship Group. For those hospitals, not all hospitals at this point in time have implemented antimicrobial stewardship programs or groups, but if they do, then microbiology should be a core member of that team. As a participant of the Infection Control Committee, the microbiologist provides expertise in the interpretation of culture results. They provide advice about the appropriateness and feasibility of microbiological approaches. They provide input regarding laboratory resources that are necessary to accomplish the goals of the Infection Control Committee and the Infection Control Plan, the annual Infection Control Plans. And they also should inform the committee of the strengths and limitations of methods that are employed to detect and characterize HAI pathogens. So in other words, there are recommendations that routine screening, microbiology screening of patients, of staff, not be done. So if you have a facility where that is taking place on a regular basis, then it's the role of the microbiologist to discuss the drawbacks of that and talk about how intense the resources are and the lack of benefit that goes along with that. Since most of the infection control and antimicrobial stewardship programs rely on microbiological results, quality assurance in microbiology is an important issue. And so every microbiology program should be conducting quality assurance on their specimens as well as on their tests. And the microbiology lab should provide guidance for clinical wards, for clinical wards and clinicians on the appropriate specimens. And the microbiology department is who should develop the policies and procedures for appropriate specimen collection and guide the training and education for the persons that are responsible for that specimen collection. So microbiology plays a key role in HAI surveillance. So this slide here describes the minimal requirements that microbiology should have in order to support IPC in the control of healthcare associated infection. The micro lab should be sited inside the hospital, and if this isn't possible, then there should be a contract negotiated for diagnostic micro with the nearest laboratory. The microbiology lab should be available every day, including Sundays and holidays, ideally on a 24-hour basis, but in the Caribbean, with our challenges with human resources, oftentimes this is not possible. But it should be open every single day, and the reason for that is because of the management of the specimens on the cultures themselves. They should be able to examine blood, CSF, cerebral spinal fluid, urine, stool, wound exudates or swabs, and respiratory secretions. They should be able to identify common bacteria and fungi that cause HAIs at least to the species level. So organisms such as Staph aureus, E. coli, Salmonella, Shigella, Pseudomonas aeruginosa, Klebsiella, Group A strep, Group B strep, Campylobacter jejuni, your Enterobacteriales, your Neisseria meningitidis, besides other common microorganisms that cause severe community-acquired infections, such as your Streptococcus pneumoniae, your Neisseria gonorrhea, and your Corynebacterium diphtheriae. The microbiology lab should be able to perform susceptibility testing for relevant antibiotics using at least the disc diffusion method. And they should be able to perform basic typing, serotyping for Salmonella, Shigella, Neisseria meningitidis, and biotyping, for example, for Salmonella typhi. And as I stated, they should have quality assurance procedures, both internal quality control and external quality control. They should have a clinical microbiologist who is able to communicate well with clinical and infection control team staff. And they may have the ability to perform simpler genotyping methods for that. And so those are the minimum requirements for microbiology laboratories with respect to the The first task of the microbiology laboratory is accurately, consistently, and rapidly identifying the responsible agents to the species level and identifying their antimicrobial resistance patterns. And as you all are aware, microbiology processes are becoming increasingly more complex. And quite often, the laboratory is the first to observe an unusual pathogen or susceptibility profile, or they may be the first to identify an uptick in the number of cases on a ward or unit. But all of this is only valuable if the results being presented are reliable. So that goes back and reflects again on the need for that quality control process. The diagnosis of infection by the laboratory department, the microbiology laboratory has two important functions. The first one is clinical, everyday management of infections. And the second is the epidemiological. The knowledge of infective microbes in a patient can lead to finding its source and route of transmission. The etiological diagnosis of HAIs is exceptionally important for targeted antimicrobial chemotherapy. And the microbiology lab is an essential part of an effective IPC program because you have very specific roles for HAI. In outbreak management, performing additional testing for epidemiological studies, you perform bacterial and fungal typing, you assist in identifying the microbial agents for HAI surveillance, and you provide reports about new alert microbes or those microbes that are showing up in the hospitals with unusual resistance patterns. The microbiology laboratory should produce periodic reports of isolates to allow the infection control team to develop incidence graphs for specific pathogens, wards, and groups of patients. And the early isolation of a new or unusual microorganism without any further typing enables the IPC team to take appropriate measures to stop it from spreading. So you can see where these are just brief examples, but the one on the left is particularly important because you should be letting the different services know the types of organisms that are present in their service. And these are just examples of different presentation methodologies. Susceptibility testing of healthcare associated pathogens. It's really important to perform susceptibility testing but the thing is that susceptibility testing relies on the implementation of multiple techniques, as you all are aware, including not only the disk diffusion, but we're seeing more rapid automated systems, as well as the need for supplemental tests such as your e-tests. And so it is important that the staff members who are performing these tests understand how to interpret these results, and also are familiar with when the results are incompatible with each other, so that they can highlight the need for either confirmatory testing or repeat testing or whatever. An example would be reporting out a staph aureus that is resistant to vancomycin, and knowing that there are so few cases that is a first of all an alert, but it needs to be a verified result before it is reported. So in doing these reports and looking for these organisms, you have to always be surveying for multi-drug resistant organisms. But when you find them, it's important to promptly inform infection control. And then the other thing is having knowledge, the knowledge of the microlab to detect the unexpected antimicrobial resistance patterns is critical in our hospital, because as I stated, oftentimes microlab is the first area to identify these unusual pathogens or these unusual resistance patterns. And so you are the persons to give us the first alerts. So it's really important that people understand what is considered unusual, and the only way to know that is to have ideas about what should and shouldn't be happening. The microlab is also involved in the detection and investigation of outbreaks. Unusual events or trends, clusters of multi-drug resistant organisms are usually first detected by you in the clinical laboratory. And so the comparison, typing or fingerprinting of epidemiologically related isolates helps to determine whether these organisms are related or not. And in other words, you are actually helping us to confirm whether or not we have an outbreak. The counterpart to the improvement of laboratory performances is the extra investment that's needed. And so it's important that a special budget to participate in infection control committees isn't always available, but it needs to be built into the context of the laboratory, so that when you are called upon, then you do have the resources that are necessary. And then in the occurrence of outbreaks, it's important to realize that the microbiology lab is often requested to store organisms, to save organisms for additional testing or typing later on. And then the other thing is that sometimes you're asked to perform cultures of specimens from hospital personnel or the environment. And when this happens, this should always be done. This should always be done only under the guidance of the Infection Control Committee. So it shouldn't be coming from a ward. It should be coming from a hospital infection control committee, because as I stated, they're just routine cultures. There is no reason to be doing them. So they do have a role in outbreak investigation, but like I said, has to be guided by the infection control committee so as not to waste scarce resources. So the microbiology lab should work. This is an example of a antimicrobial susceptibility report from a hospital in New Zealand from 2017. And the microlab should work closely with physicians and pharmacists to determine the appropriate antibiotics to be included in the susceptibility testing panels. And the microlab should provide restricted antibiotic reports to the wards according to the formulary that's used within the healthcare facility. The microlab should produce periodic resistance reports, such as similar to this, for specific wards, and hospital, and it should be stratified by the pathogen and the infection site. It is critical that reports such as that are available for every physician who prescribes antibiotics, because it helps find the local empirical therapy. So knowing what organisms are present in your healthcare facility, and then what the resistance patterns are, helps to guide the empiric therapy, the first stage of treatment in the event that an infection is suspected. But this antimicrobial susceptibility testing, this goes along with antimicrobial stewardship programs, and this is the last component I want to talk about tonight, briefly. With an increase in multi-drug resistant organisms and limited antimicrobials to treat many new resistant infections that are in circulation, it's important that we're able to monitor the rates of antimicrobial resistance. And many multi-drug resistant organisms originate in low and middle income countries, where the ability to control the spread can be limited due to the lack of resources. And with limited antibiotics continuing to be produced as the rates of antimicrobial resistance, or AMR, increase, prevention plays a key role in tackling this issue. And antimicrobial usage has seen exponential increase in low and middle income countries over the last decade. A major concern for antimicrobial resistant bacteria are the highly resistant carbapentamases. And two major examples are Klebsiella pneumonia, which is a carbapentamase, which was identified in 2001, and the New Delhi metallo-beta-lactamase 1, identified in 2008. And they're two highly resistant carbapentamases that have since been found to have spread worldwide. And limited information is available on the prevalence of antimicrobial resistant pathogens in those low and middle income countries. In data from Latin America shows that resistance to third generation cephalosporins and E. coli isolates is increasing. For example, around 60% in many Mexican hospitals, increasing resistance to the fluoroquinolones, around 60% in hospitals in Colombia, Mexico, and Peru, and resistance to the third generation cephalosporins in strains of Klebsiella pneumonia have also been documented, for example, 75% in Peru. Limited information is available for the Caribbean. However, I do know that Dr. Corey Ford from Barbados has reported on multi-drug resistant Klebsiella in his hospital. Unfortunately, increased antimicrobial consumption has exerted selective pressure, leading to the emergence of resistant organisms. And because that antimicrobial consumption is a driving factor for antimicrobial resistance, there needs to be a coordinated effort to optimize is vital for individual patient care. It can also help in planning antibiotic policy and designing local antibiotic formularies. Both antimicrobial stewardship and infection control programs are important in limiting the development and spread of multi-drug resistant organisms. And so what is antimicrobial stewardship? Well, it consists of coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of the optimal drug regimen, including dosing, duration, and route of administration. CDC designed antimicrobial stewardship programs. I'm going to talk about that in a few minutes. And WHO and PAHO have produced toolkits for helping to implement them. One component that I do want to make, because I talked about the fact that antimicrobial stewardship and IPC programs are important in limiting the development and spread of multi-drug resistant organisms. Infection control teams should be informing microbiology when they identify infections, HAI infections, with, so that the microbiology lab can then go back and tag those so that they can do HAI, that they can do the susceptibility reports for HAIs as well as across the board, because the antimicrobial susceptibility patterns will look different in HAIs than they do in community. And just to build on that, so what we're seeing is examples of the number of agents that are having increasing resistance, and they are different at the community level than they are in healthcare. And so we're all familiar with the increasing fluoroquinolone resistance in the Neisseria gonorrhea, and the fluoroquinolone resistance and the third generation cephalosporin resistance that we're starting to see in Salmonella. The strep pyogenes, the group A strep with reduced susceptibility to the macrolides, and the strep pneumos with reduced susceptibility to penicillin and the macrolides. And then the Staph aureus, the methicillin resistance, the MRSAs, but also the emergence, although it hasn't taken deep root, of the vancomycin resistant Staph aureus. So in the community, we are starting to see this. But it used to be that MRSAs, methicillin resistant Staph aureus, were only hospital acquired, and now we know that from antibiotic pressure in the community that they can also be community acquired. And in the healthcare facilities, what we're starting to see in the hospital, the carbapenemase producing Enterobacteriales, Acinetobacter baumannii, and the Pseudomonas aeruginosa, but also the vancomycin resistant Enterococcus faecium, and as I stated, the MRSAs, the methicillin resistant Staph aureus. So how do we prevent that? The implementation of antimicrobial stewardship programs helps assist hospitals in effectively implementing these programs through the use of the Centers for Disease Control's core elements of hospital antibiotic stewardship programs. And the components of the program include leadership commitment, that is, that the facilities need to dedicate necessary human, financial, and information technology resources. There has to be accountability. So there should be appointed within each healthcare facility a single leader responsible for the program outcomes. Experience with successful programs has shown that a physician leader is effective. Pharmacy expertise, they used to call this drug expertise, but pharmacy expertise, appointing a single pharmacist leader responsible for working to improve antibiotic use. The pharmacist and the expertise that they bring can talk about the effective dosing, the effective route, so their skill set is particularly important in helping to guide the appropriate use of antibiotics within healthcare facilities. Action, implementing at least one recommended action, such as systematic review of ongoing treatment needs after a set period of initial treatment. In other words, antibiotic timeouts after 48 hours. There needs to be the component of tracking. You have to monitor antibiotic prescribing and resistance patterns. You also have to be monitoring when antibiotics are being used, and then reporting regular information on antibiotic use and resistance to the doctors, the nurses, and other relevant stakeholders. And lastly, education. You have to educate the clinicians about resistance as well as about optimal prescribing recommendations. And so PAHO and WHO recommend the introduction of antimicrobial resistance action plans. All of the countries in the Caribbean have participated in this, and antimicrobial stewardship is one aspect of those action plans. And according to WHO, antimicrobial stewardship interventions should be implemented in this stepwise approach. You want to build on the existing structure and reporting that's already happening in the health facilities. You want to maximize teamwork, and the teamwork that should already be established is between micro and infection control, but infection control already has teamwork with pharmacy and with the wards. So you can see where you can start to build on this teamwork to start to implement something like an antimicrobial stewardship program. But their recommendation is to start small and keep it simple and doable so that you can work one step at a time to improve antimicrobial usage in the hospitals and other health facilities. So when in looking at antimicrobial usage, according to WHO, there are 9 common areas for improving antibiotic prescribing, which are shown here. And I'm going to present in the last few slides, I'm going to present 2 areas which can be addressed in healthcare facilities when micro provides rapid, accurate, and reliable results, and where there are regular surveillance activities for HAI as well as AMR as part of a stepwise approach. So the first suggestion is something as simple as selective or cascade reporting of antimicrobial susceptibility testing. That's one strategy for antimicrobial stewardship. So the cascade reporting, as you're aware, is when the antimicrobial susceptibility test results for a particular bug-drug combination are obtained, but results aren't reported for broader spectrum agents unless the bug is resistant to narrow spectrum agents. And this is simply a subset of selective reporting. And so what happens is, in this example, you can see that this is for Enterobacteriales. So they would report the first line, those organisms that are in the gray, and then if there is resistance in this, then they would go down to the next one. But they wouldn't report cefepime unless cefuroxime was resistant. So you can see, or you wouldn't report piperacillin, tazobactam, unless ampicillin sulbactam was resistant. So something like that was another example. Another example is this one for the same set of organisms for the Enterobacteriales. You can see you would report the group A, the cefazolin, the gent, and the tobramycin. And if there was resistance, then you could go to the next level, and you would hold these ones until the very end, because those are the ones that we don't want to. Those are the ones that you want as a last resort. So you would want them to choose from this group of drugs first, then this group, then that one as a last resort. And then this is from CLSI from the 2022 documents, but you can see this is for Staphylococcus. You could see that these are primary reporting, and then if there's resistance, then you could change down here, so you could add the linezolid, and so you would cascade down to, and these would be the last ones that you would report because they're not optimal. So that is one suggestion, and the other suggestion, the WHO Expert Committee on Selection and Use of Essential Medicines created what they called the Aware Classification of Antibiotics in 2017, and it's a tool to support antimicrobial stewardship as well. And the antimicrobials, the antibiotics, are classified in three groups of drugs. The first group is called access. The second group is called the watch group, and the third group is the reserve group. So it contains generally narrow spectrum antibiotics recommended as first and second choice for most common clinical infection syndromes. And the watch group contains broader spectrum antibiotics, antibiotic classes, and they correspond to the highest priority agents in the list of critically important drugs. And the reserve group consists of last resort antibiotics for targeted use with multi-drug resistant infections. And so these groups are collectively known as AWARE, A-W-A-R-E, AWARE. And they're given these color indications. So this is the green means go, use with caution, and then stop at last resort. So when you correlate that with a hospital pharmacy, then this is how it might show up. So the green drugs are part of the access, and then these are part of the watch group. And then when you get to something like Aztreonam or as Azactium, it's in the reserved group. And so in some countries, this may require an infectious disease physician to be on the case to prescribe a drug that has been placed on the reserve list. So clinically, that might appear something like this. So in this explanatory example, you can see here for otitis media, the first line of treatment is no antibiotic therapy. The first occurrence of otitis may not need to be treated, but if they do have to treat it, it could be, so they could go with amoxicillin, or second choice could be amoxicillin plus clavulanic acid. So you can see, and then as they escalate, you can see where they would be in the access or the watch groups. So this is how it could look when it comes to prescribing. And so on that note, I'm going to, and it is 3 minutes until 9 o'clock. I'm going to open the floor to say thank you and open the floor to any questions.
Okay, thank you so much, Kathy. As usual, wonderful presentation. You're getting some kudos in the chat. Excellent lecture. Persons are asking if it's being recorded. Absolutely, it was recorded, and we will make the link accessible to the group. Everyone that was here will receive email or text message with a link to it on the CACM YouTube site. We also, okay, I'm seeing here a comment. I'll call names. Rosanna is saying that the major difficulty in categorizing a pneumonia is that many clinicians do not routinely order imaging, and as such, it will not meet the NHSN criteria. Now, that's always an issue where we have to follow these unique, precise criteria to call a disease process an HAI when we don't have all the information. That's why it takes a team effort to look at all the various aspects in order to actually identify it. And then you did make a comment about, not trying our best not to do retrospective searches because you can miss opportunities for an intervention. Because sometimes if you don't have the patient there or the notes, the physician there to ask specific questions, and it's very hard to actually indicate whether or not this was actually an HAI. I don't know if you want to comment on that.
That's true. When you are doing it retrospectively, and it is also a way, if you're doing it prospectively and actively, it allows you to educate the team, the healthcare team, on the documentation that's necessary to be able to classify these infections. And so by educating them on that and allowing the healthcare facility to accurately calculate those HAI rates, it allows you to make better recommendations for the processes, the bundles that need to be introduced, or interventions that can be done as a team across the entire health facility that can actually help to decrease and reduce the HAI rate and its associated morbidity and mortality.
Absolutely. I think this is a question I had. I don't know if it was also a question for others. Sometimes a little bit difficult to identify. But can you tell us again the difference between the attribution period and the time of recurrence of infection? When is it that we actually get to say this is a new infection versus an old?
So that has to do with the attribution period is related to diagnosing secondary bacteremias. So secondary bacteremias are associated with that attribution period. And it means that the bacteremia has to occur within a specified time frame, the 17 days, of the other site of infection. So if you have an intra-abdominal infection and it seeds and you end up with a septicemia, say you have E. coli in your abdominal fluid, and then it has to be within that 17-day attribution period that it grows in the blood as well to be able to say that the secondary bacteremia comes from that intra-abdominal site. Now, the reoccurrence is it varies with the different types, but they're generally about 14 days. And it means that if you identify the same organism within that 14-day time frame, you don't count it as a new infection, even if it looked like the patient was beginning to improve. If it's the same organism, it's still a continuation of the original site, so you wouldn't count it again.
Absolutely.
And in addition to that too, if it's a new organism, it could be classified as a complication of the first infection, not a new infection.
Okay, so that was the next question.
Yeah.
It's a new
organism.
So,
yes, if the patient hasn't gone through that 14-day time frame, then it is categorized as a complication of the first infection, not a new infection.
Okay.
So
we have another question here. Do you think one type of bundle supersedes another? So I'm assuming, Rosanna, you want to turn on your mic and ask, or I'm assuming you mean for the various bundles available online by different organizations or institutions, if there's one that Kathy thinks is better than the other, if that's not what okay, that's what she means.
okay, so what you will find in the development of the bundles is that they're usually developed by a group of different agencies. So like you might find the bundle for ventilator associated pneumonia was developed by the Infectious Disease Society, the Infectious Disease Society of America, the Society for Healthcare Epidemiologists of America. It included the Association for Professionals in Infection Prevention and Control. So there were multiple agencies that actually participated in the development of the bundle. So they all will present it, but if you look at the content of the bundle is the same across all of the different agencies that are putting them out there.
Okay, great.
So it isn't that one supersedes the other or one is better than the other. They are targeted. They're targeted at the different, primarily the different devices or to prevent them or the surgical site.
Okay, awesome. Thank you for that. I'm not seeing any more questions. I know we've gone over the time, but okay, let's see. Okay, she says, thank you. We've gone over time, but I know this was an excellent presentation. You were very good at covering almost every area possible. Thank you so much, Kathy. I know Professor Nicholson is on board online. Well, she was online, and I know she'll probably want to adopt you into the UE family after this. I'm sure you'll have no problem with that. Kathy has been to several Caribbean countries, several hospitals in Jamaica as well, to do assessments and assist persons with lectures in basic and advanced IPC, etc. So she's an asset to any group. So I'm advertising Kathy for you. I don't know if that's allowed.
Thank you very much, Wendy.
Yes. So yes,
thank you for inviting me to be a guest lecturer in your summer series. I've enjoyed it.
Oh yes.
And I hope that the talks have been beneficial for the whole group.
I think it really has been. I think even the one last week, IPC in the laboratory, because most times we don't think about it, but it was absolutely important. It was well put together, and we really appreciate you spending this time with us. So I want to say thank you again. Thank you everyone for joining. Thank you, Kathy, for the wonderful presentation. And of course, we'll make the lecture available to everyone. We'll send out a PDF version, and we will also send you a link to the video. This has been an awesome lecture series for this summer. I know next year we'll do this again. We had a wonderful time, and we are so happy that we went out with a bang with IPC. You know, it's like the stepchild of everything else, but it's so important. I think the pandemic proved that to us. And so people are listening more and willing to participate in the activities related to IPC. So thank you again, everybody, and we'll see you again next year for another summer lecture series. Have a good evening.
Thank you. Bye.
Bye.